Hello, I'm Kevin Chambers, your host for this Medscape series on global approaches to antithrombotic treatment in non-valvular atrial fibrillation. In today's program, two internationally recognized experts are going to discuss the challenges presented by the frail patient with frequent falls and new onset non-valvular atrial fibrillation. Joining us once again is Dr. Sana Al-Khatib, Professor of Medicine at Duke University Medical Center in Durham, North Carolina in the United States. In addition, we have with us Professor Hans-Christoph Diener, Professor of Neurology Emeritus at the University of Duisburg-Essen in Essen, Germany. We're going to begin by looking at a patient who is quite typical of those seen in day-to-day clinical practice. Anna Torres is an 82-year-old woman with a history of New York Heart Association Class II heart failure with reduced ejection fraction, and also hypertension. Her blood pressure at the moment is 163/92. She weighs 47 kilograms and, like some women her age, she has fallen more than once. During one of her falls, she sustained a hip fracture, but she has not had any head injuries in the past. Mrs. Torres' most recent medical assessment revealed that she has non-valvular atrial fibrillation, as well as some renal impairment. Her serum creatinine is 0.9 milligrams per deciliter, and she has an estimated creatinine clearance of 36 milliliters per minute. She doesn't smoke or drink alcohol. However, she is taking a beta blocker, an ACE inhibitor, aspirin, and a statin. Professor Diener, as a neurologist, what would be your priority in terms of managing this patient?
Well, atrial fibrillation is one of the most important reasons of stroke. And these strokes usually have severe disability and a high mortality. And this patient is at very high risk of stroke. She has heart failure and hypertension. She is over 75 years old, and of course, she is female. So altogether, her CHEDS-VAS score is 5. And this means that her annual stroke risk is about 6 to 8%. So getting her started on oral anticoagulation to reduce the risk of stroke would be very important.
Professor Al-Khatib, would you be concerned about the risk of bleeding in this patient?
Yes, the difficulty with this patient is that in addition to having a high risk of stroke, she is also at a high risk of bleeding. The Hasbled score stratifies patients into 3 risk levels. A score of 0 indicates they are at low risk for bleeding. A score of 1 to 2 indicates moderate risk. And a score of 3 or more indicates that they have a relatively high risk of bleeding. Although this patient has moderately impaired renal function, her serum creatinine level is only 0.9, which is not considered to be a risk factor for bleeding based on the Hasbled scoring system that uses a creatinine cutoff of 2.26. However, she has hypertension. She's over 65 years of age, and she's taking aspirin. These factors give her a Hasbled score of 3, and that means she is at a high risk of bleeding.
Would a Hasbled score of 3 exclude the use of oral anticoagulants?
Not at all. The purpose of this score is not to use the absolute value to exclude anticoagulation therapy. What it does is it allows physicians to identify a patient's potential bleeding risk factors and manage the patient accordingly. It also helps inform shared decision-making. The latest European Society of Cardiology guidelines clearly state that a high bleeding risk is not a reason to withhold oral anticoagulation.
There are a number of characteristics that are typical in elderly patients like Mrs. Torres. These include frailty, which can involve low body weight, increased risk for falls, multimorbidity, and polypharmacy. Professor Al-Khatib, how important is this patient's age alone?
Well, the risk of stroke and the risk of bleeding, including intracranial hemorrhage, both increase with age. And in somebody like Mrs. Torres, who's over 80 years of age, the risk of major hemorrhage is almost 3 times higher than it is in somebody under 80 years of age. In recent years, many clinicians have moved away from warfarin towards DOACs. And this shift is especially important in the elderly, who don't do well on warfarin due to bleeding risk, especially intracranial bleeding, and who commonly discontinue taking the medication.
Are there any data comparing warfarin and DOACs in this population?
The Aristotle trial compared the factor Xa inhibitor apixaban against warfarin for the prevention of stroke or systemic embolism in patients with atrial fibrillation. It showed that apixaban given twice daily was associated with a lower risk of stroke or systemic embolism, caused less bleeding, including intracranial hemorrhage, and resulted in lower mortality than warfarin. When the results were assessed according to age, the benefits of apixaban were even more pronounced in those over 65 years of age, and greater still in those aged 75 and over.
There are questions in the mind of many clinicians about the implications of low body weight for the use of DOACs.
Yes, the anticoagulant effect of DOACs is closely related to their plasma concentration, which in turn is related to the patient's body weight. So it is reasonable to expect that extremes in body weight may affect the efficacy and safety of these medications. And in general, increased bleeding has been observed in underweight patients taking a DOAC. However, DOACs have been shown to be a much better option than warfarin in underweight patients. Data from a large, widely cited Korean registry on the use of DOACs for stroke prevention in patients with atrial fibrillation and low or very low body weight found that compared with warfarin, DOACs are associated with lower risks of ischemic stroke and major bleeding. And in the Aristotle trial, the relative risk of bleeding appeared to be lower with apixaban compared with warfarin in patients with low body weight.
In anticoagulated patients, frequent falls are associated with an increased risk of traumatic subdural hematoma and mortality. It's been reported that the most common reason physicians cite for withholding anticoagulation in older patients with atrial fibrillation is the risk of falling and associated bleeding, especially intracranial hemorrhage. Professor Diener, would you be concerned by Mrs. Torres' history of falls?
I would be concerned and cautious, but the history of falls certainly does not override this patient's need for oral anticoagulation to reduce her risk of stroke. I give you an example. In one study of patients with atrial fibrillation at high risk of falls, the rate of traumatic intracranial hemorrhage was 2 per 100 patients years. And this was compared with an ischemic stroke rate of 13.7 per 100 patient years. Therefore, anticoagulation offers a clear net benefit.
How does the risk of intracranial hemorrhage in patients treated with DOACs compare with the rate observed with warfarin?
Well, with respect to the incidence of intracranial hemorrhage, DOACs have been shown to be statistically superior to warfarin. The risk of subdural hematomas, either spontaneous or traumatic, is reduced by 50% with DOACs compared to warfarin. For rivaroxaban, however, there is less benefit with respect to intracranial bleeding, and in elderly patients, there is a twofold increase in the risk of gastrointestinal bleeding events compared to warfarin. Though these things must also be taken into consideration. But overall, for a patient like Mrs. Torres, in whom I would be concerned about subdural hematomas following a fall, a DOAC is clearly preferred over warfarin.
Until around 5 years ago, warfarin was the only oral anticoagulant with a specific reversal agent, prothrombin complex concentrate and vitamin K. And despite having clinically significant advantages over warfarin, one factor that slowed the adoption of DOACs was the absence of a specific agent to reverse the anticoagulant effects of those therapies if necessary. Therefore, the introduction of specific reversal agents for use in patients treated with DOACs was an important advance. Professor Diener, let's suppose our patient was on dabigatran and she did fall and experience intracranial bleeding. Do you think that administration of a reversal agent would help her?
Well, idarucizumab was approved in 2015 to rapidly stop the anti-clotting effect of dabigatran in patients who either develop life-threatening bleeding or require emergency surgery. It is a humanized monoclonal antibody fragment. that binds non-competitively and irreversibly to the bigotron. Idarucizumab provides complete reversal of anticoagulant activity within minutes of injection, and it has been shown to be effective and safe for normalizing the coagulation system. And if our patient did fall and experience intracranial bleeding, there is a strong probability that the administration of idarucizumab could improve her clinical outcome.
Now, clinical outcomes following dabigatran reversal is something you've looked quite closely at, isn't it?
Yes, that's correct. We looked at data collected from neurology and neurosurgery departments in Germany over a period of the last 2.5 years. And this analysis included 40 patients who had suffered intracranial bleeding while on the bigotran, 27 of whom had intracerebral hemorrhage. Among those who had intracerebral hemorrhage, only 11% of patients experienced hematoma growth with clinical worsening. And this rate is lower than observed in times when the reversal agent was not available. The rate at this time was in the range of 40 to 59%. And the mortality rate among those with intracerebral hemorrhage in our study was also quite low, slightly less than 15%. And this is much lower than recently reported 90-day mortality rates in cases of DOAC-associated intracerebral hemorrhage, which are between 25 and 40%.
Professor Al-Khatib, isn't there also a reversal agent for factor Xa inhibitors?
Yes, if a patient who is taking rivaroxaban or apixaban develops bleeding that we are unable to quickly get under control, we now have the option to use andexanet alpha, which is a recombinant modified factor Xa protein. At the moment, however, there isn't sufficient data to allow for its use in edoxaban-treated patients.
How effective is it for allowing you to stop the bleeding in those situations?
Andexanet is administered as an IV bolus over 15 to 30 minutes, followed by a 2-hour infusion. It quickly becomes attached to either rivaroxaban or apixaban, inhibiting them from binding to natural factor Xa. Infusion of andexanet fully restored thrombin generation in 100% of healthy apixaban-treated subjects within 2 to 5 minutes. In a large study of rivaroxaban and apixaban-treated patients who presented with acute major bleeding, infusion of andexanet over 15 to 30 minutes reduced anti-factor Xa activity by 92% at the end of the infusion. Among the group of patients who could be evaluated for hemostatic efficacy, 82% achieved excellent or good hemostasis. If andexanet is unavailable, prothrombin complex concentrate or activated prothrombin complex concentrate, which were developed for warfarin reversal, can also be used as an alternative for management of factor Xa-related bleeding.
In addition to atrial fibrillation, Mrs. Torres has moderately impaired kidney function with a creatinine clearance of 36 milliliters per minute. This is not unusual. Atrial fibrillation and chronic kidney disease commonly occur together. Nevertheless, it is a complicating factor, as all DOACs are eliminated to some degree via the kidney. Professor Al-Khatib, how does our patient's impaired kidney function affect her anticoagulant therapy?
All DOACs are eliminated to some degree via the kidneys, and impaired renal function is a criterion for dose adjustment. Consequently, assessment of kidney function is recommended when anticoagulant therapy is being initiated, and then at least once a year after that.
So, if a patient does have impaired renal function, would you reduce the dose of anticoagulant?
Sometimes, but not always. Dose modification should be considered for all DOACs based on the patient's renal function. Approximately 80% of dabigatran is eliminated by the kidney. For patients with a creatinine clearance of 15 to 30 milliliters per minute, the usual dose should be reduced by 50%. Based on the ROCKET AF study, the dose of rivaroxaban should be reduced by 25% for patients with a creatinine clearance of 30 to 49 milliliters per minute. And based on the Engage AF TIMI study, the dose of edoxaban should be reduced by 50% if the patient's creatinine clearance is between 30 and 50 milliliters per minute, or if their body weight is 60 kilograms or less. For apixaban, impaired renal function alone is not a reason for adjusting the dose. Based on the Aristotle trial, the dose of apixaban should be reduced by 50% if two of the following criteria are met. They are 80 years of age or older, their weight is 60 kilograms or less, or their serum creatinine is 1.5 milligrams per deciliter or greater. So I think that regardless of the DOAC prescribed for this patient, it would be appropriate to reduce the dose.
Would warfarin be an option in your view?
Not really. The advantages of DOACs over warfarin have been consistently demonstrated, even in patients with poor renal function. In fact, the relative reduction in major bleeding associated with apixaban compared with warfarin appears to be greatest in patients with impaired renal function.
Unfortunately, we're almost out of time. Professor Diener, what are the most important things for viewers to take from this program?
For me, it's two things. In the Averroes trial, where we compared apixaban in patients who did not qualify for warfarin, the second most frequent argument presented by general physicians for not using warfarin was the risk of falls. And this seems to be the case for the direct oral anticoagulants as well. But the reduced risk of ischemic stroke with these agents far outweighs the small risk of intracranial hemorrhage or subdural hematoma due to falls, though this precluded a lot of patients in the past. And the second important aspect is that beyond prothrombin complex that was approved for the reversal of warfarin, we now have specific effective reversal agent for most of the DOACs.
I absolutely agree with Professor Diener's point about falls. A history of falls alone should not preclude clinicians from offering patients anticoagulation. An analysis of the Aristotle trial showed that patients would have to fall hundreds of times to get to a point where the risks of anticoagulating them outweigh the benefits. Advanced age and the challenges commonly associated with it should not be factors that discourage us from anticoagulating these patients. We just need to optimize the safety of how we do it.
Given the number of elderly people with atrial fibrillation, those points sound like important considerations. Thank you both for taking the time to speak with us today. And thank you for watching. As always, I hope you have found this program interesting and helpful in your own clinical practice. In the fourth episode, we'll be looking at a patient with atrial fibrillation undergoing percutaneous coronary intervention for acute coronary syndrome. Please join us then. In the meantime, goodbye for now.